to our presentation today on fetal alcohol spectrum disorder and justice-related issues. I think this is a topic that many people are interested in and a very important topic, and we know that people signed up for this very quickly today, so we're very pleased about that. So my name's Sandie Leith, and I'm currently the co-chair of the Provincial Human Services and Justice Coordinating Committee, and I just am here to host this morning. So we're just going to start out by, if you have any questions, you can just type them in the box on the left-hand side. So just put it in the chat box. The PowerPoint presentation will be emailed to you following the webinar, and we'll ask you to please complete the brief evaluation survey following the webinar. Okay, people want me to speak louder. Okay, so the Human Services and Justice, you're aware, is a network of committees across the province. The provincial committee, as one of our mandates, is promoting webinars, so we're really pleased to have this presentation today. We're going to have the presentation, then we'll have open question and answer period at the end. So today we have Cheryl Neave, and Cheryl is the chair of the FASD Ontario Network of Expertise, and Cheryl's been active in the field for the last 14 years. She was helped to develop the provincial call to action and delivered FASD presentations to over 1,000 physicians, nurses, psychologists, social workers, and other service providers. And we know how important it is to get the information out to people. I'm also pleased to introduce Sheila Burns from the Justice Action Group for FASD Network of Expertise, and Sheila is also an FASD consultant. She does training and consultations, and she's been working in the field at FASD since 1997. She's a founding member of the FASD Ontario Network of Expertise and has held leadership roles in many capacities. So we're really pleased to have both Cheryl and Sheila here today with us. So just a little bit more information about the HSJCC. We respond to recognize needs in the province to coordinate resources and services and plan more effectively for people in conflict of the law. And we included in our priorities is people with serious mental illness, developmental disabilities, acquired brain injury, and certainly fetal alcohol spectrum disorder is one of the areas that we're quite concerned about. So we have 57 committees across the province, both local and regional, and the provincial committee that is made up of people from the regional committees as well as ministry representatives and several other ex officio members. The network at this point is funded mainly through the Ministry of Health and Long-Term Care. So the committee, the ex officio members, which include ministry reps from Attorney General, Child and Youth Services, Community and Social Services, Community Safety and Correctional Services, and Health and Long-Term Care. So together we're working on breaking down some of the silos and addressing some of the issues that affect the people that we work with that come in conflict with the law. So for information about the network of Human Services and Justice, we do have a website and we encourage you to connect with that. You can also join our mailing list to receive information about webinars and a newsletter that we produce every couple of months. So there's lots of information on the website and we encourage you to have a look at that. At this point, we're going to ask people to do a survey. There's a quick poll, and that is if you could select the sector which you represent, and if you represent more than one sector, you can answer more than one question or type in more than one. So we'll give you a few minutes just to do that, if you can do that quickly. If your sector is not listed, feel free to enter an additional sector. what a great opening slide we have for the presentation. So that's great. Okay, I think people are still registering, selecting their sector. Okay, I think we're going to move on. Okay, great. Thank you. The poll is now closed, and we'll move on to the presentation. Thank you.
So good morning, or good afternoon. The learning objectives for this session, we're going to talk about the FASD-1, a call to action. We're going to do a quick primer about FASD, talk about FASD and justice, the relevance of the mandate of the HSJCC, and have some time for questions and answers. Good night. So this slide shows you the incidence and prevalence rates. Individuals with FASD are heavy users of the system. Adverse outcomes reflect a poor fit for services versus needs, rather than innate disorder traits. And these poor outcomes contribute to stigma associated with the disability. So FASD-1 was founded in 2005, formerly called the FASD Stakeholders of Ontario, with funding from the Public Health Agency of Canada. Our aims are to prevent FASD and produce better outcomes for individuals living with a disability by advancing the development and dissemination of best practices. We're a volunteer collaborative that includes caregivers, practitioners, specialists, physicians, and many other groups. So as we were building our call to action, we brought stakeholders from around the province together, and they included caregivers and a lot of service providers. The call to action reflects the growing understanding that a multi-sector, coordinated, and collaborative response is required to address the needs of FASD prevention and effective intervention. The call to action addresses the need for parallel and concurrent action to shift programming parameters and protocol and policy frameworks to ensure adequate accommodation and interventions for optimal outcomes. Highlights of the call to action are in 5 areas, and they are awareness and prevention, assessment and diagnosis, supports and interventions, knowledge transfer, and research and evaluation. So the call to action, number 1, prevent FASD by providing evidence-based information and accessible, comprehensive services to pregnant women and all women of childbearing age. Number 2, ensure timely access to assessment and diagnostic services to children, youth, and adults who may be affected by FASD. And number 3, support children, youth, and adults who are affected with the disability through evidence-based interventions that stabilize home life and maximize potential.
Thanks very much. Thanks, Cheryl. It's Sheila Burns speaking now. So when we were approached to do this, I thought that it would be helpful for us all to kind of be on the same page related to the disability. So I put together a quick primer on fetal alcohol just so that we all kind of understand the basics of the disability. As Cheryl mentioned, the justice is not, or conflict with the law is not intrinsic to this disability. It often reflects the poor fit of services, late diagnosis, and the fact that our system hasn't kind of caught up to this disability at this point. And really that is the efforts of FASD-1 and specifically the Justice Action Group that I chaired for 2 years, and now I'm just a member. Can I advance slides? Mm-hmm. Only with the clicker thingy? Okay, there we go. All right, so what we know about alcohol and its impact on pregnancy is that the alcohol dehydrates and kills brain cells, and it diverts the cells from becoming what they were supposed to be, alters them so they don't become what they need to be, and affects the expression of genes. And there is just some really fabulous and intriguing research being done right now that's exploring the full impact of alcohol on the fetus. Every year we learn so much more and fine-tune our understanding in different ways. Today I'm really going to talk about the high points about the disability, though. So what we know is that the brain develops throughout gestation. It makes it much more vulnerable than other parts of the body. And we also know that the outcomes for individuals are based on the timing of the alcohol exposure, that you'll get some facial dysmorphology if it's in early first trimester, other effects later in the pregnancy. We know that the more you drink, the more risk there is to damage. We know that there's genetic components that we still don't fully understand, that nutrition appears to have an important factor in outcomes, and that maternal health, how well mom is, has some implications on the degree of damage that is caused in the developing fetus. So not every woman who drinks alcohol during her pregnancy will have a child with a disability, but we know that beyond any doubt that alcohol does impact the developing fetus, and the damage is permanent, and it's organic, and it's a neurodevelopmental disability. And in the last number of years, we've changed the terminology to refer to fetal alcohol spectrum disorder that helps us identify that there are degrees of damage to the developing fetus. So the primary disability, so this is what the alcohol changes in the brain function, because really we're talking about the disability. It really is about brain. Because while there is some facial dysmorphology, that's less important to us because you can go through life looking a little funny, but if your thinking is really funny, you're in big trouble. And so we know that there are profound impairments typically in executive function, so that's your ability to plan and organize your life and make age-appropriate decisions, your adaptive function, your ability to look after yourself. Sensory integration in terms of how the environment, noise, light, movement, how all of that impacts you, that there may be challenges in the filtering of that. We're understanding more and more the profound implications of social communication impairments, the ability to process, interpret, and respond to language, verbal and nonverbal, is significantly impaired. And unfortunately, or one of the strengths associated with the disability is that expressive language is often quite good and is less impacted. We're not exactly sure why that is, but so that means that we typically have a population who speaks better than they are, and it can have a real camouflaging effect for hiding the deficits in thinking that are so often at the center of the challenges faced by our clients. We have clients who will mimic or parrot or embellish ideas and the words of others, and that can throw us off as well, because we then misunderstand what they misunderstood. And we often think that we have some compliance when in fact they have not comprehended what our meaning. And we see processing deficits, their ability to follow directions, hearing all the content. There may be intermittent hearing, mishearing, and of course the retrieval of meaning. And almost always memory and sequencing is affected, and that can implicate issues related to when and where things happened, determining fantasy and reality. We often have kids who fill in the blanks for us when we would rather they not. But from a justice perspective, what this looks like, I was given a case study about a year ago by someone from Kitchener, and I think it really highlights how individuals with this disability end up in conflict with the law when their intention was not was completely benign. We had a staff present that she had a client who's very scruffy and messy looking. He speaks with a slur, so he's got some muscle dysregulation in his mouth, and so there's an articulation issue that sometimes occurs with fetal alcohol. He's very friendly and chatty, and so he's got lots of words, but not he has very poor social communication. So he's standing at a bus stop and started to speak to a woman he did not know, and he didn't read any of her body language to pick up that she was feeling really uncomfortable with the conversation. So he started to ask her what she was doing, where she was going, where she lived, how she spent her free time, and his questions became intrusive, and she was a stranger. So she was so uncomfortable that she called the police. So when his account of the story was that he was stopped by 2 police cars on his way home from work and asked for ID. I showed them my health card. That's all the ID I have. The police asked where I worked and my telephone number, and I answered them. I asked the officer if I could call the agency who supports me with my cell phone, and he said no. The officer talked about me over the radio and asked if he could frisk me. I said yes, but didn't know what that meant. So I got mad when the officer put gloves on me and touched me. The officer put me in the police car and told me my rights. I was arrested and taken to the special room at the police station. They asked me if I wanted a lawyer. I said yes, and I asked them to call my support agency. They took all my stuff and cut off my bracelet. My girlfriend gave me that bracelet, and I was mad. The officer asked me if I do drugs. No. Drink. No. Suicidal. No. They thought I was crazy. A man named Dan came in. I have no idea who he was. Then the lawyer phoned, and he told me the police could keep me here, and I don't have to talk to them about this situation. He asked more and then hung up the phone. The Dave guy asked me questions like the lawyer about stalking a girl. We talked for a while about this girl. Dave left and came back with papers that I could sign and told me I could go because they were dropping the charges. I don't know what the police thought I did, but they should do their research before arresting someone. So you can see how this young man who's got this disability, how much trouble he got in just by having a conversation at a bus stop, and how the things that he agreed to have done were things he did not understand. You know, now the young man was in his early 30s, but he didn't understand the meaning of being frisked. He was completely over his head in terms of the implications of stalking someone when that was nowhere included in his intent. So we can see how the disability can get in the way of just everyday life for individuals with this disability. Even though he was asked if he wanted a lawyer and spoke to the lawyer, he continued to speak to the police officer, not recognizing that Dave was somebody different because he would not have been in a uniform, so he didn't look like a police officer. So this young man was very vulnerable, and now, of course, he's known to police. So what we have with folks with this disability in a very simplistic way, and this is Diane Malvin's slide from many, many years ago, is that we have red brain thinking. That we have a brain that wasn't structured properly during gestation, and so leaves them with profound deficits in the way that they can cope and understand and process the world around them, as opposed to the rest of us who, if we got here on time and with our green brain thinkers, that our brains are fairly well organized. We've got lots of brain where there needs to be brain, and well-organized filing cabinets, as opposed to those with individuals with fetal alcohol who may have the information, but nothing's filed well. And so what else we have related to the disability is that this is what they look like when they're 18. So this again is Diane Malvin's work from the mid-90s, and it is still holding up today. That we have, as we had with the case study of the young man, we have skill sets that are incongruent with the age. We have a young man who had great expressive language, but incredibly poor comprehension. We also have experience of individuals who we know that they struggle with time and money. Their emotional maturity is delayed, equivalent to a child in grade 1, but they look age appropriate. They have some reading strengths typically, but very significant weakness in terms of their social skills, and their living skills are equivalent to a child in grade 5. So that you can see how having looking your age and talking your age would make you assume that you can act your age, but that is not the case with individuals with fetal alcohol. And that's one of the reasons why. Okay, do we want to do that poll now? Yeah. Okay. So we're just going to do a quick poll at this point, asking who has worked with individuals with who are diagnosed or suspected of having FASD.
And there was a comment about someone said stalking is a difficult term for most of us. This should be defined to make it acceptable to everyone. Do you want to comment on that? Or?
Can I do that now? Okay, if someone has asked a question about stalking, that stalking was the word that the police used. It is typically that when you follow someone and they don't want you to. Okay, so we've got some good. All right, so we'll move on. Thank you so much. So we're seeing a preponderance of people who have whose lives or work are intersected with FASD, and that's not surprising considering the field that you're from. It's interesting. The first poll showed 45% of you are working with youth justice, and I've done some research in that area. But just in terms of the interface of FASD and justice, that youth with fetal alcohol spectrum disorder are 19 times more likely to be incarcerated in a given year than their non-affected peers. And the trend continues into the adult sector, that we have 28 times more greater likelihood of being incarcerated. And we see the commonness in recidivism rates, that typically the offenses don't become more, they don't escalate. We see more repeat offenses, breaches of probation, violation of parole, that missed court dates, that type of that type of charge. And then what's been picked up by colleagues of ours who work in closed custody is the vulnerability of inmates who have fetal alcohol. When you look back at this slide to see that their social skills, their communication skills are so impaired that they have limited problem-solving skills. In fact, that's often how they end up in jail, so that they are vulnerable to victimization. And that it can be intentional or unintentional, that these are folks that can organize themselves to have their jails, their confinement shifted, that they're not going to meet programming requirements in order to shift the degree of custody, many things like that that are kind of the odds are stacked against them. So if we know that we have a significant population in a close custody with fetal alcohol, one would assume that we would have programs that are designed for individuals with cognitive delays, and we're not finding information on that. So that they get stuck in the justice system. To help us understand this better, in 2013, the FASD One Justice Action Group did a survey that we circulated among the HSJCCs in the province. We wanted to see the perceived prevalence rates of fetal alcohol in justice-related services, and to understand how justice and corrections track the disability, to identify current FASD activities in the province, and to identify some priority issues. While we weren't, we feel that that this is a bubbling, emerging issue, and we wanted to find out who had it on the top of their agenda and was doing some activities that could help inform Ontario. I'm just going to take a little bit of a back up here. So we know that there's poor outcomes associated with the disability, as identified in the graph that Cheryl had presented. And she also talked about stigma and blame associated with FASD. And I just wanted to talk for a moment about the moms who give birth to kids with this disability, is that they're at a profound risk of early death. And that we're seeing that if you have a child with the disability, you're 45 times more likely than other women not to reach your 50th birthday. That's a profoundly important piece of information for us to have, because it tells us that we've got a mom who's really at risk. We've also seen a trend in recent years about increased incarceration rates for women, and we know that many women have mental illnesses and addictions, and incarcerating them without providing adequate supports for those issues is going to be unhelpful for them in the long run. And then we see high rates of their children in child protection, their school dropouts, unemployed, and homeless. And so now we can see the cycle of the failure of the system to respond and recognize and respond to FASD. Breaking the Cycle is one Ontario-based program that does some lovely work in terms of the parenting support treatment with women who have FASD themselves and or whose children have the disability. So the call to action through the justice lens suggests that FASD is preventable, but the messages, our messages need to focus on the pregnancy planning, because so many of us drink alcohol. We need to be planning the pregnancy so it can be alcohol free. We need to support and have better supports for women who are substance involved, and we need to understand their needs better. And we also need to understand and support women who have fetal alcohol themselves. They've gone through their lifespan with inadequate supports often, and that contributes to their risk lifestyles. So in terms of the prevalence from your colleagues, related to FASD, you could see that while there were a few agencies who did not perceive that they had any of their any clients had the disability, we see that many between 5 and 15% of agencies, more than 70% of agencies felt between 5 and 15% of their clients had the disability or suspected their clients had their disability. And as that number progressed, you see that suspicion rates increase versus the diagnosed rates. And that's important because we need to have a pathway for staff when we suspect FASD. We need to clarify disability in order to ensure that we provide adequate supports and interventions for individuals with FASD. What we see in some BC research that was done through the Asante Center, and they have got a great website, and some is that we see that we can identify individuals with a disability when they're much younger. We're seeing a trending pattern of learning and mental health issues, learning and ADHD, learning and growth deficiencies, learning and developmental disabilities, plus child protection issues, maternal alcohol use. That those are the kinds of factors that we should be looking at. We also know that that if you're involved in child protection, that there's increased incidence we see a lot of FASD in foster and adoption care, and so that we should be able to identify this disability before difficulties occur. So the Justice Survey findings, we're looking for how we track the disability. Since 2005, Canada developed the diagnostic criteria for FASD, but we often are seeing individuals who have a diagnosis, but because we don't have a lot of information on FASD or a lot of FASD-informed programming, sometimes those diagnoses are lost. And so we wanted to understand how agencies tracked the diagnosis. And we see that while there are multiple opportunities for it to be tracked, we need to ensure that we don't rely on self-reports, because it's not going to work out well for us. Individuals with the disability may not be aware enough of the importance of sharing this disability, or they may not know they have this disability. And if we don't find out early, we miss opportunities to ensure that we're providing adequate care plans for individuals with the disability. So we know, I referred to the diagnostic guidelines. They're currently under review, but we do need to have access to diagnosis so that we know exactly what we're working with. The survey findings identified suspicion of FASD, and so we need a pathway for diagnosis, so that when you're suspicious of this disability, that you know what to do and who to go to. And there are protocols in the province already that is so that we can have pathways for diagnosis. So we need to track better, and we also need a response for when we're suspecting FASD. When we wanted to see who was doing something in the province related to innovation research pilot projects, evaluation and training, we found there wasn't very much. The most significant response was training, and we're seeing a lot of training related to the disability, and some of that is just one-off, and others it's actually integrated into staff orientations, it's annualized, there's a sense of thoroughness. But what we see is that there aren't a lot of programs to complement or support the training. So what we've got is some good information, but we don't have the tools, the program tools to implement the training. And that is that is required for us to get a good systemic response and improve outcomes related to the disability. Some highlights that were identified, that we've got some youth Crown attorneys who are checking prevalence rates. There's some enhanced extra-jurisdictional sanction programs up north, video conferencing for assessment and diagnosis. There's some collaboration for other kinds of diagnosis, court diversion for mental health programs. And that's not a bad fit for fetal alcohol, although it's not a mental illness, it's a developmental disability. Certainly we need to be diverting individuals with this disability away from the standard court process. As you could, the case study indicates how easy it is for somebody with this disability to have something happen to them that they didn't intend. A young man did not understand what the word frisk meant, and so was then touched without his informed consent. So we see that there are some initiatives, and the Justice Action Group is going to explore some of those further and have a report published early next year that will disseminate through through the HSJCCs. But when we look at the call to action, we need to consider issues related to moral blameworthiness and proportionality of crimes and breaches. We need to look at the rights of victims, accused, and offenders, and other neurodevelopmental disabilities. Fetal alcohol is only one of many neurodevelopmental disabilities that put people at risk and needs a more nuanced response. And we have some models that can help guide us. The mental health courts, diversion programs, and GLADU reports and courts are appropriate to help the courts understand some of the innate vulnerabilities of individuals with this disability. Our justice findings in terms of priorities that were identified, lots more training, even though that's the most people were identified lots of training opportunities. It does not appear to be enough, and we need programs that are nuanced and responsive to clients with this disability. Specifically, case management and long-term support is needed. I mean, this is a permanent developmental disability, so we need to ensure that there's a support system to address the lifelong needs of individuals with this disability. So we, in terms of knowledge transfer and capacity enhancement, we need to understand the origins of the challenges so that we can do a better job, and sharing what we know is vital, and that's why it's wonderful to have this opportunity to present today. And we need to, the learning about FASD isn't that hard, but it's the changing of the programs and our interventions that needs to be different. How we shift from theory to practice is vital. And some of that requires the systems change. We need more flexibility, and we need permission to do things in a different way, and to ensure that we're getting effective outcomes. We see the respondents from the survey identified there were lots of concerns around vulnerable clients and offenders. They were concerned about victimization inside and outside of institutions, and they felt that many identified the wonderful qualities that are associated with individuals with the disability. They identified their earnestness and loyalty, that they were creative and artistic and kind and helpful, and they felt that the system was set up against them, so we were missing the value individuals with FASD can bring to our society because it's being washed away by all of the negative attributes by our poor response. And so what we see with fetal alcohol is that it does feel a bit like the Titanic. But what we know about the Titanic was there was a whole lot of stuff that we could have done to prevent it. If we'd had somebody else on the bridge, it wouldn't have hit the iceberg. We've often looked at fetal alcohol like it was the Titanic, that it's already sinking. But I want us to choose a different picture. I want us to look at the things we can do when we know we've got a brain injury, and that we can have something like 51st dates, where the whole community surrounded a young woman who was known to have a brain injury and protected her and gave her a safe place to live and a rich and lovely life. And we can look at Gilligan, because we just know Gilligan had to have FASD. He has all the qualities of it. And look at who was around him to make sure that he could contribute all of his charm and skills and talent to that community. That we do need to start looking at fetal alcohol differently, so that we can see the joy that individuals with this disability can bring to our lives, and the talents they can bring to our communities. So we know that we need to evaluate what we're doing, and that the status quo isn't good enough anymore, and that we can't afford to, in every way, we can't afford to continue doing what's not working. And that with some good research and evaluation, that will help steer us in the right direction. So we know that we need to track FASD better, and we need to use some screening tools and assessments to help guide us. We need referral and diagnostic pathways, and we need plans of care protocol for our clients with FASD diagnosis or suspected FASD. And in the absence of prenatal history, we still need to be comfortable with protocols for individuals with a neurodevelopmental disability, cause unknown. We don't know what causes autism, but we can develop treatment strategies for individuals with it. The same goes for other neurodevelopmental disabilities. And we need to have FASD-informed programs that help support and scaffold individuals with the disability, rather than relying on their red brain thinking, which has not worked out well for them or for us. And we need to coordinate our services across the full spectrum of agencies that are involved in the HSJCCs to contribute to stable lives. So what we know is that there are models that already exist in the province. The HSJCCs is one of them. And we know that there's some government leadership that has begun to move us towards more effective interventions associated with the disability. And in terms of the FASD1 call to action, that we need all HSJCCs to put FASD on their agenda, to strike working groups or to collaborate with existing community committees or networks. I think there's 35 FASD committees in the province, so there's potential there for some collaboration. You need to identify your priorities, engage stakeholders to address gaps and systemic barriers, and to address obstacles in policy and programs. And then we can change the environment, because that's what needs to happen, because in order to improve outcomes for individuals with the disability. And the FASD1 action group is available to facilitate some planning needs. Here's a list of resources for you, and Cheryl's and my contact information. And we've got one more poll. Just if people could identify what their priority concerns are related to FASD and justice, and we'll take the questions for the next 10 minutes.
So I'm just going to go back and read some of the questions. So from Corrine, Corrine asked, why is it so challenging to find mental health agencies willing to accept individuals diagnosed with FASD, in particular adults? This is a group of people who have needs, but our agency and partner agencies are unable to support due to a lack of resources.
Especially for adults, what we often have is we have adverse outcomes that include mental illnesses, and so that they can look like they're really complex care, and so that they slip between the cracks of mandates. And I think that's just has been a consistent experience by families, is that nobody wants to have folks with this disability. In part, I think part of it is because we're not sure how to serve them well, so we don't serve them at all, or that it requires us to provide we have to shift our programming up to meet the needs of individuals with learning impairments that are part of FASD, and we don't always have some good collaboration around that. So they just fall through the cracks. And until agencies realize, I mean, it can be a really hard disability to support, and you all have to do it together. And it's that kind of collaboration that puts you in a better shape to support individuals with the disability.
So Jennifer asked if you could explain the term GLADU reports in a bit more detail.
GLADU, somebody can, you can correct me on this if you like. GLADU, it was R versus RV GLADU, a case in, I think it was 1999, and it required courts to evaluate or consider in judgment in criminal cases the implications of systemic of the history of Aboriginal offenders or Aboriginal accused. So they had to consider the systemic injustice. I think is the best way I can put it. Systemic injustice that has affected First Nations people more significantly, that appears to contribute to the high prevalence rate of First Nations people who are in conflict with the law.
Thank you. And we have a comment from Anita Parker, who says a GLADU report is a type of pre-sentencing and bail hearing report that a Canadian court can request when considering sentencing an offender of Aboriginal background under Section 718.2E of the Criminal Code. And then Anita has offered, if folks are interested in GLADU, to contact her. So that's great. So we're just going to move to our next question. Can the speakers speak to the intersection of trauma, poverty, chaotic home life, and how we can help mitigate these? We need systems change as well as work with the individuals. And this is from Emily, and she finds that a lot of her work is in dual diagnosis and individuals with complex needs.
Well, in terms of placement stability, if we could just start with there, that would be really helpful. So that in my practice, what I see is that we get kids are taken from their families, so we start working on some destabilizing and some building in some trauma there. But we move them from perhaps what was not a good home life into foster care. We don't tell the foster parents, or they don't understand who it is that they're having come into care, so they don't have the right information to parent them as if they have a developmental disability. So that we see placement breakdown after placement breakdown. So then that starts to contribute to some trauma because things aren't going well in their lives. I did a consult during the summer on it was the little boy's 5th birthday, and he was working on his sixth foster placement breakdown, and he'd had 2 adoption breakdowns too. And it was because they didn't have good information on what this disability looked like in him. So that is the challenge, is that we have to get these folks settled in some place that can nurture their skills. We spend so much time focusing on the things they can't do, we miss looking at what their strengths are. And we have to stop doing that. And then it's then once they're stable that we can start to work on the relationships. We can start to build some strategies to ease their mental health issues. But we have to start with housing first. And having a support network around them, go to people who can help keep them safe.
So there's 2 similar questions from Graham and Dawn. So Graham says, I work with a 17-year-old male who I suspect has FASD. I have had a lot of difficulty connecting him with medical and mental health services. Where might I turn for a diagnostic pathway? And then Dawn said, I find it dealing with FASD and trying to get services for adults is very difficult, and when made available, very expensive and not covered under medical benefits. Is there any other diagnostic pathways suggestions you can give? So diagnostic pathways.
All right. Well, that is it's amazing to think that somebody's 17 years old and we're still suspecting. I'm not. There are Sick Kids has does FASD assessments. There are Anishinaabe Health does them. If you're local, I would take the issue of diagnostic pathways to your HSJCC. What I often see is kids with this disability who have multiple psychological assessments, and that we assess them not for an organic disability, but we assess them, we look at ADHD or ODD or trauma or anxiety, so that we get kids with, so look to your assessment first. And then you'll have to work within your community to build a pathway if there isn't one already there. In terms of who pays for psychological assessments, that's always going to be a challenge. But this is what I know about them, is that they cost less than a day in court. And that we need to look at the importance of understanding kids, especially as they transition into adulthood. If we haven't got a 17-year-old diagnosed yet, he's at risk of just rolling into the adult system without a diagnosis. And that means he's not going to get the services that that should be available to him. Supported college if he's been able to last that long in high school, ODSP if that's appropriate, developmental services if those are appropriate. So it's really important that you look for that. The FASD1 website has a list of diagnostic facilities that we're aware of in the province. So that website is fasdontario.ca, and you might want to check that out to see if there's something in your local area.
So thank you for that. We have one question about FASD and gender identity disorder. Is that something that you can speak to, or?
I think that's really interesting, but no, I won't speak to that.
Yep. So one, Holly is asking, how would one go about getting a client assessed for FASD without evidence of prenatal alcohol exposure? And again, another question about completing an initial diagnosis. I think you spoke to some of this already.
So but that's a great, we can kind of roll on this one. The assessment that is required that contributes to an FASD diagnosis is a standard neuropsych or psychological assessment. That it is the same I see them all the time. It isn't a special assessment, but it does factor in, and I apologize for not including that slide in this presentation. But it evaluates psychological assessments evaluate function in different areas of the brain, and that's what we need. There are 9 areas of the brain that are looked at for fetal alcohol. So all of the tests are tests that are currently within the toolkit of psychologists already. It's nice if you can get a speech assessment to understand how communication is understood, and occupational therapy to understand how people experience their environment. So and then it does require the one test that is new is the facial dysmorphology test, and that is a computer program that MDs would use most typically to measure the eye, the philtrum, and the upper lip. That just rules in or out fetal alcohol syndrome. If you don't have a prenatal alcohol history and you don't have the face, but you do have evidence of brain damage to standard deviations below the norm in 3 areas of brain function, we can say that you have a neurodevelopmental disability. The cause is unknown. If you know that there was prenatal alcohol exposure, then it can become one of the diagnoses under the umbrella FASD.
So we're just going to do one last question. I know we're going a few minutes over time here. So the last question, which I think is really good, Ellie asks, many programs for persons with disabilities will reject clients based on criminal involvement. Can we talk about how to advocate for our clients?
Yeah. Oh, the advocacy for your clients is probably it is what will change the system's response. That because it's such a catch-22. We don't serve them well. They go through their life stumbling through, being blamed for things they didn't do or things they didn't mean to do, and then we tell them that they can't join programs. That actually, if they'd been involved in those programs earlier, they would have their outcomes would have been different. So the advocacy piece, and what a great way to end this presentation, is just critical. This is where we need to see flexibility in terms of programming, that we can't exclude someone because they have a disability that we haven't understood well and haven't supported them and provided the resources that they need. That's just intrinsically unfair. So I would encourage all of you to advocate and to bring this issue to your planning tables, so that when you suspect you've got somebody with a disability or you have someone who applies to your program, that you are able to organize yourself to feel confident to go forward and to reap some of the good outcomes that agencies can find when they stretch themselves.
Great. Well, I just want to say a quick thank you to Cheryl and Sheila for such an informative webinar and for answering all of those tough questions from our audience. This is a really interesting topic and one that many of our HSJCCs come faced with on a day-to-day basis. So we really appreciate you coming to speak today. And thank you all of you for joining us online, and we will be sending a recording as well as the slides to you shortly. So thank you.